Good morning, everyone. Welcome to the Southwest Ontario Regional Base Hospital Program Paramedic Rounds webinar presentation on 12-lead ECGs and STEMI bypass. My name is Stephanie Romano, and I'm one of the regional paramedic educators with Base Hospital. Hopefully everyone has had the opportunity to either be with us during one of our webinar practice rounds or during the stroke webinar rounds presented by Dr. Duclo a few months ago. But if you do happen to be new to this design, I'll run through a few quick points with you. So right now, you should be able to see the first page of our presentation with the 12-lead ECG and STEMI. Sorry, the 12-lead ECG and STEMI title, and Dr. Carolyn Church's name underneath. Dr. Church is a fifth-year emergency medicine resident and will be presenting the bulk of today's webinar. Also in the background are Dr. Mike Llewell, who is your Regional Medical Director. He'll be jumping into the presentation to add some key points and will be available for questions at the end of our presentation. Also, Dave Vucic, your Education Coordinator, will be available to answer any chat questions that you might have during the presentation. So a few key things to notice here are within your control box. If your control box isn't open, just pass your mouse over the top of it and it should reappear. At the bottom of your control box is a chat area where you can send questions in or make comments about the presentation. So Dave and Dr. Llewell will be actually receiving these questions and we'll be able to answer them for you. You'll also see a thin vertical tab at the upper left-hand side of your control box where you'll have the option to raise your hand. If you choose to click on the hand, we'll be able to see that you've raised your hand and that you'll have a question. Now, keep this to the end of the presentation when we'll open this up to everyone so that you can ask questions. If you have a microphone or headset and we've opened that discussion to questions, we can actually unmute you so that you can then ask that question. Now, this is the only time that you'll be able to speak and have everyone hear you. Otherwise, everyone will actually be muted throughout the presentation to minimize any background noise. So if you have any other questions throughout the presentation, please feel free to type them in the chat box and we'll gladly answer them. So I'd like to introduce Dr. Carolyn Church, and I hope you enjoy the presentation.
All right, good morning. I'm Carolyn. As it says on the sheet, this is technically my presentation, but really I'll just be doing the play-by-play and Mike will be doing the color today. So if you can't hear us, if you have any problems, just send a chat message, and that way the guys here can inform us whether or not we're too far from the mic, or basically if Llewell's talking too much, any of those problems, you just let us know.
It's true, Church. We have 55 slides to get through, so we got to move.
We have a motor.
Here
we go. There we go. So just to start off with the objectives, what we're going to do is, hold up. There we go. The objectives are to describe the anatomy and pathophysiology associated with cardiac ischemia, cardiac injury, and cardiac infarct. Relate the appropriate steps for acquisition of the 12-lead ECG, and identify the presence of a STEMI, determine the location of the MI on the 12-lead ECG. So that'll be the fun part. All right, we're going to start off with a review of the anatomy and pathophysiology, which for most of you guys, again, is review. We'll just talk about first the start of the impulse of a cardiac contraction starts in the sinoatrial node in the right atrium, or the SA node, as most people refer to it. Travels down towards the AV node, and then through the His-Purkinje system out through the right bundle branch and the left bundle branch. The left bundle branch has two fascicles, the left anterior and the left posterior, which are a pain for me because it took me years and years to try and decide which one was which and where they're going from. Thankfully, we don't need to pay too much attention to those. Moving on, again, the coronary arteries. The main coronary arteries are the right main and the left main, which are conveniently named after where they go. So the right coronary artery goes toward the right ventricle and the left coronary towards the left ventricle. Take a look at the diagram here. You can see that they actually exit through the aorta just after the aortic valve. These areas get highly calcified, which is the whole pathophysiology of myocardial infarction in the first place, because there's high flow there. As the blood is ejected from the left ventricle and out through the aorta, it's going very turbulent past these two orifices or outlets there, and trying to feed the heart as well as going to the rest of the body. We're going to take a look at the three specific arteries: the right marginal artery, the left anterior descending, LAD as most people call it, and the left circumflex. Each of these arteries supplies a very specific area of the heart, which we can see on our 12-lead ECG. So starting off with the right marginal artery, it feeds the inferior wall of the left ventricle, posterior left ventricle, and predominantly the entire right ventricle. It can also feed the the posterior fascicle of the left bundle branch, and 50% of the population, the SA node, is fed by the right marginal, and the AV node in 90% of the population. So when you have conduction problems in initiation, it may have something to do with the right coronary artery.
And that's when you see like an inferior infarct happen, or an RV infarct, or right ventricular infarct. You tend to have very slow heart rates as well as potentially low blood pressure. And remember, your whole job of the right ventricle is to actually send blood to the left ventricle to give you the stroke volume and give you cardiac output. So if all of a sudden you lose your right ventricle, the only thing that's going to actually fill your left is your preload. And so for that reason, that's why we're so cautious about giving anything that's going to drop your preload, such as nitroglycerin, or for those ACPs that are giving morphine, the same thing. What I always found odd has been you're having actually an acute MI, your pump is failing, and if you're actually hypotensive, the first thing we do is actually give you fluid, because that actually improves your preload and actually restores your blood pressure. You want to see a bunch of nervous nurses, actually what you do is when you're in the trauma room or someone's having an acute MI, you say, we should give the guy 500 cc's of saline, and then all of a sudden they're looking for a different doctor, a smarter doctor.
Yes.
But then you have to explain what preload it is, and by that time the guy's in the cath lab.
So you can just take a look at the diagram there with the right marginal artery coming straight down towards the right atrium and right ventricle, and then over towards the left, so you can see that entire territory provided there. As far as the left coronary artery goes, it takes a massive area of the heart. You can see it comes down the lateral portion of the left ventricle in this diagram. What we're going to talk about is the left anterior descending, which is the second major branch. The first major branch is the circumflex, we'll talk about next. You can see it climbing over the edge of the heart on the lateral side there. But the left anterior descending has the anterior part of the lateral wall of the left ventricle and the major pumping mass of the left ventricle. It also includes the septum, which we'll talk about later on, which leads to the septum and the major portions of the bundle branches. And when you include that left main coronary artery right up at the top, you're talking about the biggest muscle area of the heart. So that would really suck.
Well, those are the ones that you can see that are going to come in with the, if you're ever going to see someone in congestive heart failure or cardiogenic shock, and if you truly are in cardiogenic shock, meaning like in pulmonary edema and hypotensive, these people have an 80% mortality. So the anterior infarcts are the ones who pay the closest attention to. The inferior infarcts, while they may seem bradycardic and hypotensive at times, they actually do well overall, whereas the anterior ones are the big ones that really, if you're losing half your LV, then you're going to have significant morbidity and mortality down the road. Even if you survive your infarct, you're going to have significant CHF issues down the road, and we know that also is a big marker for poor 5-year survival if you have significant CHF.
And lastly, moving on to the left circumflex, which is the first branch there that's wrapping around the lateral portion of the heart. It does the upper lateral wall of the LV, which are seen in leads 1 and AVL. The other half of the population, it feeds their SA node, an AV node in that last 10%. Also the posterior fascicle of the left bundle branch. Again, it's not labeled on your diagram here, but it's climbing around the posterior portion of that picture on the lateral side of the left ventricle. And again, it's also important in terms of the pumping mass, but it's not as significant as the LAD in terms of the muscle mass that it provides. All right, we'll go on to the little bit of review. We'll go over it quickly. So electrical flow, there's upward deflection on the ECG when the flow is coming towards you, and downward deflection when the flow is going away from you. So something down in the left anterior chest where the predominant flow is going to show up more positive when you're looking at your anterior V1 through V6 leads. You should be able to see the transition as it's going more and more towards you and then sliding a little bit away.
And the importance of that was always lost upon me, but really that's how the ECG machine actually figures out where the actual impulses are, where the actual leads in the heart are, because as it can actually sense, okay, well, I'm getting a lot of R wave because the current's coming at me, and then it can figure out, since you know the direction of the overall vector of the actual electricity going through the heart, it can figure out where on the myocardium it's looking. It's looking at the septum, it's looking at the apex, based on this upward and downward deflection.
So for those of you who are a bit more visual, we've got some good pictures coming up to actually show what Mike's talking about there.
Sweet.
That would be good. More review here. The vertical lines are measuring time in seconds, or sorry, milliseconds, and the horizontal lines are voltage in millivolts. So things like obesity, so big distance between the heart and the chest wall can decrease your voltage, as well as small contractions or patients with a pericardial effusion or things like that might decrease your voltage. And then time, of course, is important when assessing an ECG overall to look at the cardiac rate.
When you look at someone with a very low voltage QRS, as Carolyn alludes to, you can actually tell quite a bit from an ECG because they're either very large in terms of a body habitus, or else they have something like a big pneumothorax or a pericardial effusion or a pleural effusion. Those are basically insulating the heart, causing you to have low current. So low voltage QRSs come with a significant differential. It's also important to note, you can see on the slide here, the actual time intervals with each one of these. QRS width is actually measured in time. So if things are traveling outside the conducting system, and that's why we showed you the review slide of the conducting system, it takes longer to actually move through muscle, although it's possible, but it takes longer. And that's manifested under ECG as a wider QRS. So anything that's not traveling down the normal conducting system takes longer, thus it'll be a wider QRS complex. And that's why things like bundle branch blocks are actually wide. And people get confused with the word block because they think, well, that's a rhythm problem like Mobitz or Winky block, but bundle branch block just refers to an abnormality in the conducting system.
So we have these super specialized fibers of the conducting system, the his Purkinje. When it's not working, it's slow. You want to take a quick look at that to make sure that the conduction pathway is appropriate. With that wide QRS, you're moving through muscle instead of specialized tissue, like Mike's saying.
I always say that if you can drive your Ferrari down the 401 and go very fast, you can also drive your Ferrari down a cornfield, but you're not going to go very fast. But then again, why would you do that?
Yeah, no, not so much. If I had a Ferrari.
Well, that'd be awesome.
Yeah. Okay, so quickly, 0.04 seconds for the small boxes. The big boxes, including 4 small boxes, are 0.2 seconds, and 5 big dark squares are 1 entire second on ECG paper. Just a quick review. And then taking a look at the morphology, a Q wave, of course, is any negative deflection that precedes an R wave. So we'll talk about Q waves a little bit more and why or why not they're not exactly that important to us, but Mike will make fun of them shortly, I'm sure. The R wave is the first positive deflection in the QRS complex, no matter where it occurs in the complex. So the that first upward stroke is always going to be the R wave, even if it occurs after a Q wave, after an S wave. And then lastly, the S wave is the negative deflection following the R wave.
And depending on what lead you look at, you may have all S wave, you may have all R wave, depending on as you move across the precordium, for instance, V5, V6 tend to have mostly R wave, whereas you have mostly S wave in V1, V2. And then as you get used to looking at cardiograms, you'll notice that all of a sudden sometimes the actual pattern of the R waves are completely reversed, and that either implies that you got your leads on backwards, or else it implies that that person has an underlying problem, for instance, a right bundle branch block or some other, like a posterior infarction or something else that's giving them an early R wave. So as you get used to looking at cardiograms, you'll start recognizing these patterns. It's not just random. That takes a long time, though.
Absolutely. And looking again quickly, as we're obviously going to move into ST elevation, and where do you measure that ST elevation on? So the ST segment, of course, is at the end of the QRS complex and moving towards the T wave, or the repolarization of the myocardial tissue. But we need to measure that off the TP segment, which is looking in towards the next complex, so at the very completion of the T wave, and then moving towards the initiation of the P wave. So in this particular example, they're exactly equivalent, showing that the baseline of the TP segment is the same as the ST segment, knowing that there's no ST elevation or ST depression in this. So if you're having trouble and you're bouncing around in the back of the rig, make sure you find that TP segment, take a look at it with some type of straight ruler or anything that you've got with you to show your baseline, and then you can look at your ST segments from there.
Especially if we're going to make calls about ST segment elevation, if you're in some sort of STEMI redirect program or you're worried about someone having an acute MI, you really want to make a decision based on the STs on a static ECG, someone when they're still, and that's why doing them on scene may be a bit better than doing them in the back of the rig So one good clean cardiogram is very important. So we may get a false activation or a false notification to the ER of an MI coming in when actually it's just wandering baseline, and it can be a certain challenge certainly in people.
Yeah, but I don't really mind waking up cardiologists.
Yeah,
well, okay. All right, let's move on to the J point. So J point is at the completion of the ST, or is where you need to look for your ST segment elevation. So the J point is where the transition is marked between the QRS complex and the start or the initiation of the ST segment. Anything else you want to say about that, just to clarify it?
Well, this is a point that always confuses people, I think, is we're always looking for ST segment elevation, and when you see ST segment elevation, I think the take-home message is think injury, ischemia, or think infarction. It's really difficult to distinguish J point elevation from ischemia for injury, and the computer is really good at that. So sometimes you'll be looking at your printout, your ECG, and you'll be like, well, this looks like ST segment elevation to me, and then you'll show someone has more experience with cardiograms, and they'll be like, oh, no, that's just J point elevation. Well, that's a difficult decision to make, but again, the computer is actually very good at that. So if any time someone's blowing off your cardiogram, perhaps it is J point elevation. It literally is where everything all of a sudden heads to the right. So things are going up and down vertical, and all of a sudden you can see the pattern on the second QRS complex just heads to the right. That's your J point elevation. Common in young males. The younger you are, the healthier you are, similar to benign earlier polarization, you're going to get a slight J point elevation.
Another way that in the emergency department we cheat to look at whether or not people have J point elevation is to compare it to previous cardiograms. So you guys don't have that benefit out there, whereas we do with the Muse system, and we can take a look at somebody's previous cardiogram and see if it looks the same in terms of morphology. So erring on the side of caution and not calling it just J point elevation is where you want to start off with.
And the precordial leads tend to be the worst ones for this. Like V1 through V3, you'll see where you see the highest amount of J point elevation, I find.
Mm-hmm. So what are we looking for? We're looking for ST segment elevation measured at the J point in comparison to the TP segment. We're looking for greater than 1 millimeter of elevation in the limb leads or greater than 2 millimeters in the precordial chest leads. And this has to be present in at least 2 anatomically contiguous leads. So we'll talk a little bit about why those are different. There's 1 millimeter in the limb leads and 2 millimeters in the chest leads. And this goes back to what we're talking about with voltage too. The chest leads are right over the heart. You're looking at probably the shortest distance possible to get towards the heart and to measure that electrical activity. Whereas out on the limbs, it's a little less accurate and can be a little less subtle. So we're looking for something that's very small out on the limb leads and a little bit bigger at the chest leads. And this has been researched and looked at a bazillion times before deciding upon this. And really, it's kind of crazy that you're talking about 1 millimeter of difference, but it does make a difference.
For sure. And I think one topic that always confuses people is anatomically contiguous. So what do we mean by anatomically contiguous? Big word for the morning.
Yes, it's too early for that, isn't it? So when we're talking about anatomically contiguous leads, we're looking at limb leads that are checking out the same area of the heart. And like I promised, we're going to see some good pictures for people who are visual learners to take a look at that. Now, we talked about the coronary artery anatomy and showing that different areas of the heart are fed by different coronary arteries. So I'm talking about the left circumflex artery sort of feeds the lateral portion of the left ventricle. Well, that's nowhere near the right ventricle. So if you're looking at leads that are measuring ST elevation in the right ventricle, leads that are measuring ST elevation in the left or lateral portion of the left ventricle, those are two different areas of the heart, and they're not contiguous. So what we need to pay attention to is what areas are fed by the same vessels, whether or not they're in relation on the cardiogram, and whether or not they're next to each other in the tissues, or else you may have some other spurious things going on in your ECG.
So when you look at a 12 lead, when you're just getting used to getting your first 12 leads ahead of you, it's important to organize your thoughts looking at 12 lead in terms of those territories, just like Caroline mentioned. So you're looking at the inferior leads, which happen to conveniently be in the bottom inferior component of the cardiogram, and you're looking at the chest leads, which are on the right side. And as it says here, numerically consecutive chest leads. Well, sure, this is why you have a septal or an anteroseptal or an anterolateral MI. So they can all blend together as long as they're fed by the same artery. And you can have an infrolateral and you can have an infraposterior because these are all fed by the same arteries again. But you're not going to have an infraanterior. In fact, when you get an infraanterior, you see like ST segment elevation in two areas fed by two different arteries, you have to think of more of a global insult to the heart. So some have had a cardiac arrest and now it's got reperfusion injury, so now they're going to have global ST segment elevation. or someone with a more of a diffuse pattern, like for instance pericarditis, where the entire myocardium is inflamed and getting ST segment elevation. So non-territorial versus territorial ST segment elevation is the key. When you plug up an artery, unless you're having a super bad day, you don't tend to plug up both of them all at once.
Yeah, that would be some really bad luck.
Yeah. Although I think it happened to me once.
Yeah. Why am I not surprised? So taking a look at electrode placement, just quick review, V1 and V2, fourth intercostal space, one to the right of the sternum and one to the left of the sternum. You're putting on V4 next at the fifth intercostal space at the mid-clavicular line, shown in blue on the diagram here, and then V3 gets to sit nicely right between V2 and V4. 5 is at the same level as 4 at the left anterior axillary line, and 6 at the same level as V5 in the left mid-axillary line. So taking a look at the lead placement, obviously getting the two parasternal leads are really important, and trying to get the right place at the fourth intercostal space, as well as the V4 lead is important, because you're basing all your other leads off the V4 lead. And then taking a look next at the limb leads over on the right side of the diagram there. So watch Betty run, or whatever it is, the mnemonic that you use.
Yeah, what is that? I mean, I never understood that. There's like white on right is right, or I never understood all that. But you know what's really I found really helpful is that they're all labeled. It says RA, like right arm. That's super helpful. We got a question coming in here. With J-point elevation, is this something you would see in every lead in 12 lead, or in just certain leads? Mostly it's just certain leads. You don't tend to see, and it all depends on the actual cardiogram. But as I said before, I think it's mostly V1 to V3. You tend to see what looks to be an ST segment elevation, and we tend to blow it off and say, well, that's J-point elevation. And again, the diagnostics that are part of the ZOL or the Life Pack, whichever unit you're using, are very similar to the 12 leads we use in the hospital, and they're very accurate for J-point elevation. They're pretty good at that. So if you're rarely will you see a cardiogram that says acute MI, and it is not, versus it doesn't tend to miss the actual ST segment elevation that's non-J-point elevation. So at the end of the day, though, it is a judgment call. We look at old cardiograms, we look at their story. If someone comes in with crushing retrosternal chest pain and they're 55 and they've been a smoker and they're diaphoretic and it's going down their shoulders, I'm not going to blow that off in being J-point elevation. Otherwise, well, then all of a sudden I'll be working a blockbuster video next week.
And one of the other points about J-point elevation is that it's pretty common in young, healthy men. So that's one group that can be a little bit tricky to determine, because you do see acute ST elevation MI in young men. Unfortunately, they're probably going to have a good family history or a history of cocaine use or something else that's going to put them at risk for STEMI. But young, healthy male with J-point elevation is also going to have sort of a cove look to their or I guess a concave look to the ST segment afterwards, not the elevation or the looking like a humpback or a camel's back or anything of an ST. So even the morphology of it that's getting a little bit more technical, which we can probably look at a more individual basis. But J-point elevation is a tricky one, and it can take years to be able to make that call. Like the cardiologists take a look at it and sort of toss it back at us sometimes. But I'd rather be erring on the side of caution than working a blockbuster. So.
And I think that really it speaks to your familiarity with cardiograms, and this is why even looking at normal cardiograms is important, because it's kind of like looking at your hand. Like the back of your hand, you recognize that's your hand because you see it every day. And same sort of thing, like if you look at cardiograms every single day, you get used to that sort of familiar pattern. And it's really difficult to describe what a normal cardiogram looks like, but it's very easy to describe what an abnormal cardiogram looks like. So if you get used to seeing normal, 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 and all of a sudden you see something, boom, that looks totally different, well, that's the sort of pattern where you go, well, I still can't explain to you what a normal cardiogram looks like, but I know that this is not a normal cardiogram. This is very bad, and we'll see some good examples of some very bad ones later on.
Okay, and the slide again is just electrode placement. And now we get to one of the more fun ones.
Just on that last slide, though, if we go back, this as you move to the one of the common errors I see when we're actually putting 12 leads on people is we forget that if we're going to follow the same intercostal space, it actually curves slightly upwards. So we tend to see people when they do 12 leads, they may actually put the lateral leads, V5 and V6, in a descending fashion. But remember, as your rib comes around, it actually arcs up a little bit. So you should see at the very least a flat line for your V5 and V6, or slightly arcing up, tracing along the intercostal space. Sorry to interrupt.
Okay, now for the visual people and the color coding here. We're going to take a look at the distribution or the names of where the infarct is going on, and try and relate this back to what we talked about with the coronary artery anatomy as we're looking at it. So as Mike had said, let's start off with a nice and easy one. The inferior region is read by leads 2, 3, and AVF, and they're color-coded in yellow on this picture. And then we'll move over to the anterior leads. First, V1 and V2 are septal, which is part of the left ventricle, and looking from your 2 fourth intercostal spaces on either side of the septum, or sorry, either side of the sternum, looking at that septum. These are all anterior left ventricle again. So V3 and V4, the in 2 in green, are anterior and big bulk of muscle of the left ventricle. And then the lateral portion of the left ventricle is V5, V6, AVL, and the high lateral lead of 1. So those are color-coded in pink. So that's the only one, the tricky one. Everything else kind of goes in order or flow, except for looking at the lateral leads.
When you look at the cardiogram here too, I remember one night I was in medical school and I was trying to learn to read a cardiogram. We had an exam the next day and I'm going over and over again trying to figure out which leads and what. And you can have any kind of acronym that helps you understand, but one day it sort of dawned on me that in the middle of the night that I could never remember where the inferior leads are. So I remember that it's on the bottom left, that's the inferior leads. And also if you just look at the anatomy of the heart, it also kind of makes sense that your RCA, your right coronary artery, tends to be on the right side of the heart like the inferior leads are here if you're actually looking at the heart. So the 12 lead actually makes sense from an anatomical point of view. If we were actually to superimpose that previous diagram with the blood vessels on it, it actually seems to make sense. Failing all of that, if you look at the Roman numerals 2, 3, they look like eyes, and then there's also an F in this in AVF, so it looks like inferior leads. If you look at the high lateral, there's an L in the AVL, and there's an I here, so high lateral. So that's what got me through my exam in medical school, but let's not tell anybody about that. And make sure you ignore AVR, because that's like that awkward cousin at your family reunion that sits by the punch bowl. You just don't talk to him. You just leave him be.
So I'm pretty sure all of you know Mike, and to me that seems kind of crazy and confusing. I like to see the visual stuff. I like to actually be able to relate it to something visual, whereas Mike's got all these little mnemonics and all this crazy stuff to explain it, but some people understand it better that way. Whatever works for you.
Whatever you do, I like AVR. It's like my medical student lead. I give it to the medical student and say, well, what do you think about AVR? You can hear like the sound of crickets.
Cruel and unusual punishment. So moving on to the pictures, which I like, again, it does relate to exactly the anatomy. If you can picture the heart looking up like the diagram over in the left, the furthest one on the left, then those leads do follow that. The right coronary artery coming off furthest to the left, looking at 2, 3, and AVF. 1 you got to kind of ignore there. But the left main coronary splitting into the circumflex artery, which is going around the corner. Well, those are the weird leads, V5, V6, 1, and AVL, the ones that are, I said, you know, it's going to be a little harder to remember which ones those are. Well, that guy is kind of going right out of your picture. You're not really sure where it's going. Well, that's 5, 6, 1, and AVL. And then looking at the LAD, or the left anterior descending, you've got V1, V2, V3, and V4 predominantly supplied by that. This picture is color-coded to show those. The main bulk of the left ventricle shown on the furthest left side, V3 and V4. The septal leads, also the left anterior descending, V1 and V2. And then looking at the posterior side of the heart, over at the base and inferior region, 2, 3, and AVF. So that one unfortunately is flipped, and you have to think through in a three-dimensional way to see that as well. But
right, so the standard 12 lead, if you remember, there's anterior, there's lateral, there's inferior, but there's not actually posterior leads on a routine 12 lead. So you are going to basically, if you think about what's the opposite of anterior, it's posterior. And what's the opposite of ST segment elevation? It's ST segment depression. So really, truly, what you will see, usually in the septal or anterior leads, and a pure isolated posterior infarction is in the ST segment depression in V1, V2, and V3. And so what we used to do in the emerge is we'll take the cardiogram and hold it up to the light and flip it upside down. And I was doing that one day in the emerge, looking at the cardiogram upside down and backwards at the light, and then it suddenly dawned on me that this isn't all that confidence inspiring in front of the patient that's having an MI. She's like going, I think it's that doctor's first day. He's got the cardiogram backwards. And he's looking at it upside down. Someone help me.
Well, basically what we'll do in the emergency department if we see significant depression in the anterior leads is try and determine if that's ischemia, or if that's infarction, acute ST elevation in the posterior side. So we'll add on some leads and do a 15-lead ECG. That way we get to keep the ECG technician downstairs a little bit longer and they can't scurry away about their business. But then we can take a look at the posterior side of the heart based on the electrical components of the ECG with 15 leads. Actually, we're just moving a couple of them, but that's what it's called.
And many people, every time I've taught the 12-lead course, the question always comes up at this point, well, should we be doing 15 leads in the field? Well, anyone that's going to have a posterior infarction is going to have significant ST segment change on their anterior leads, and so by and large it's not going to change our management. So at this point, no, I wouldn't spend the time on scene looking at doing 15-lead ECGs, because we know it's going to cost us at least 2 or 3 minutes in scene time, and these are the sickest patients because they're about to VF. So so those are the ones we need to get into either the cath lab or get into the emerge. But the key of this with regard to your early 12-lead is it shortens our door-to-needle time if we're doing thrombolytics, or it shortens our time to cath lab if we can do it quickly. So important.
Okay, so next we're going to do a breakdown of some of those visual things that we went over very quickly. Well, let's talk about the inferior wall myocardial infarction first, 2, 3, and AVF. Have we beat that in a few times?
Well, about an inferior wall infarct, that's the one we talked about. That tends to be the bradycardic and hypotensive one. And I think this is really, if you look at the way your protocols are written, really remember, a 12-lead is another piece of information. It's another diagnostic as well as prognostic thing for the patient, but it doesn't change our protocol. So we've actually embedded into the protocol safety for right ventricular infarcts or inferior MIs, because what do our protocols say about nitroglycerin use? Well, if you're bradycardic or if you're hypotensive or if you drop your blood pressure significantly with any dose of nitroglycerin, then you withhold it. Because as we're designing these protocols, chances are if you're a hypertensive anterior infarction, you can probably give that person a ton of nitroglycerin. It's not going to change their management. And they're not going to drop the pressure. They're going to do very well. But if you're a bradycardic hypotensive right ventricular infarction, you drop their preload, you're going to plummet their blood pressure into their boots. So that's why we pay such careful attention to saying heart rate less than 60, blood pressure greater than 1/3 drop, no more nitroglycerin. And so the protocol doesn't change, but of the ones that are going to be hypotensive, it's going to be the RV or inferior infarcts.
And when you see those out there, take a look and see 2, 3 AVF. And commit that to your memory as one of those abnormal ECGs that should be associated, not always, but is usually associated with that bradycardia and hypotension. So visual learners, again, the principles or the electricity principles of the ECG are a little bit too advanced for this right now, and I'd have to do a lot of review to even talk about that. But essentially when you're looking with these 3 leads, you're looking from the left foot, looking up at the heart and getting a nice picture of that inferior portion of the heart, predominantly the right ventricle. And again, just another visual reference, looking at those 3 leads on your 12-lead ECG are going to be in that bottom corner, left leg looking up.
And this is such an important cardiogram because back before we did 12 leads, you would go see someone and they'd be complaining of chest pain, and they'd be like, well, I'm having some significant tightness or heaviness or whatever the description is, and we usually hook them to lead 2. So you'd be hooking them on lead 2 and look at your rhythm strip on lead 2 here, that's your rhythm strip. So if you were to ever look at ST segment elevation, even though you're only in monitoring mode, not in ECG diagnostic mode, which is a different monitor mode that your defibrillator will switch to when you actually hook up the 12-lead cables. But you can see here the 12-lead, the lead 2 is a very normal looking strip. Yet if you look to the right here, and as we move to the septum and the V leads, this person's having an enormous anterolateral MI. So they've clogged up their LAD, yet everything looks hunky-dory over here fed by the right. So we used to have medics come in and say, well, I thought he was cardiac, but lead 2 looked okay, so I withheld nitroglycerin. No, you don't hold or withhold or give nitroglycerin based on the 12 lead. You give it based on the signs and symptoms. If you look at the actual protocol for nitroglycerin, it's very clear what the indications are, and nowhere on that is what the ECG showed. So stick to your protocols.
Okay, let's move over to the left ventricle, and again, those funny leads, the 1 AVL, V5, and V6. So this is actually a better diagram here. We can actually see that lateral portion of the left ventricle. We haven't had those pictures in the previous slides, so just for you to get a visual and take a look at that, especially the one on the left there. And this picture is being taken essentially from the left arm, and that kind of goes back into determining where lead 1 comes from. AVL is definitely over on that left arm as well. So you're looking over at that portion of the heart, taking a picture over there. So ST elevation on that side is going to be laterally and shown like this in this ECG here. And again, those inferior leads are still completely normal from a practical standpoint, like Mike was just talking about. If you did have only lead 2 running, this would look normal as well. Okay. Again, V3 and V4, the big honkers over here, important guys from a major bulk of left ventricular muscle. ST elevation of V3 and V4 is looking at the apex of the heart, the left ventricle down there, the big pumping and generating force that starts down at the apex and squishes all the way up to get that blood pumping out through the aorta.
We have a question here, Carolyn. Is there a visual landmark for a fourth intercostal space which is hard to find on an obese patient? Well, your fourth intercostal space is just roughly approximately just below your nipple, but then again, in certain patients, the nipple may be down significantly lower depending on the size of the patient. So therefore, really at the end of the day, if you look at spreading your hand, intercostal markings are pretty standard. So if you spread your hand from the clavicle down and spread your hand apart, now remember there's great variability in the size of people's hands as well, but basically if you put 4 fingers below the clavicle, that is pretty much where your fourth intercostal space is. Tremendous variability in that, but really, if you're within the same area, is that really going to affect your 12 lead? Not really, if you're off by intercostal space or not. So don't be concerned about if you're off a space or not. Just get the 12 lead done, and we can always change the landmarks later. It may change our T-waves when we compare cardiogram to cardiogram, but by and large, if you're off a space, I wouldn't sweat it.
The last little piece I would just add to that is the axillary hairline is pretty reliable for most patients. So the axillary hairline should be about the fourth intercostal space. So if you're using Mike's technique first and then you can just lift up their arm, I might make a really inappropriate joke here, so I'm going to move forward.
Fair enough. So you're doing like a cardiogram on like a Yeti or something?
So the axillary hairline, or the inferior portion of the axillary hairline, even if they've shaved, should be right about the fourth intercostal space, and you can use those techniques to help you out.
Good to know. Good to know.
Okay, sorry, this ECG is again just referring to V3 and V4 ST elevation here, the anterior left ventricle, big suckers.
Yeah, that's an impressive MI, isn't it, though? I mean, if you look at this, it's like we call those ST segment elevations so fast, Jim.
You're out. Moving on to the septal wall, V1 and V2, again, part of the left ventricle, looking basically directly into the heart there. Because of the positioning of the heart, it is still left ventricular predominantly. Even though you're along the sternal border, again, the orientation of the heart and the chest makes that mostly left ventricle. And ECG here, it's the same one as below.
Right, and so this nicely is a good example of what we were trying to allude to earlier. So contiguous leads would be anything on the precordial lead. So this is kind of like an anteroseptal infarct, but it's even extending laterally because it's a big proximal lesion of your left anterior descending. So potentially even left main. So you're really hitting a big, juicy, large proximal portion of the artery versus something peripheral.
And like we talked about, occluding the left main before it branches is potentially the worst. Well, it's not potentially. It is the absolute worst one. So if you're Jim and you have a left main lesion, you're in big trouble.
And those are the ones that usually have VF. So those are the ones that will be clinically of significant crushing chest pain, and all of a sudden they'll fibrillate on you, and
yeah, it's
usually proximal left main.
Because their heart's really pissed off.
Well,
it's really
I
pissed
wouldn't
off.
be annoyed with that.
But if you saw that and you're looking at this cardiogram, you're going to see ST elevation in V1, V2, V3, V4, V5, and then again in the lateral leads, because the left main coronary also spreads that left circumflex, which you're going to see in V5, V6, 1, and AVL. You're going to see extensive ST elevation if you had a left main coronary lesion.
But yet again, lead 2, everything is all good in the ship.
Hunky-dory.
That's right. Keep going.
Okay. Let's talk really quickly about acute myocardial infarction progression. So looking at these, we'll just go over these really quickly. A is a normal picture, and then initial ischemia, you're going to see the first changes are hyperacute T waves or peaking of T waves. There's a pretty large differential of why you would see peak T waves, but if you have a good story, crushing chest pain, the guy's sitting there with about 6 packs of smokes next to him, he looks like he's been in his lazy boy armchair for quite some time, then seeing those peak T waves are going to give you some pretty significant concern. And what does that mean? That means you might want to repeat the cardiogram in transport as you're bringing the guy into the hospital. It might change, it might evolve on you.
And we see that with a stuttering beginning of some people's MIs. They'll have, here comes the pain, it's really quite significant, and then all of a sudden it seems to abort itself and come back again, which way you can actually physically watch the T waves go up, and then the ST segment will come up and join it.
Yeah. So again, that's moving into C with your ST segment elevation, or the first evidence on the cardiogram that we actually have injury to those myocardial cells. In B, with the hyperacute T waves, they're pissed off, but in C now you're getting actual injury to those cells. D is here, you know, not such an important one for us to look at, because right there what they're trying to show us is a Q wave, or that's dead tissue essentially. So a Q wave is an abnormal wave, which we'll talk about in a little bit. And then moving forward to E and F are not so significant, but that's when you see some of those patients who have kind of abnormal looking cardiograms, and you're saying, you know, they look like F. They've got this little, you know, initial negative deflection, your Q wave, the QRS is a little bit wide, and the T wave isn't as pretty as it used to be. That's somebody who's probably had a previous MI, and this is their new normal. So we get the benefit of being able to compare it, whereas you guys look at it and say, this doesn't quite look normal, but I don't think that something's going on right now.
Operationally, that's very important, because your computer will actually spit out inferior infarct, age undetermined, or anterior infarct, age undetermined. And when it says age undetermined, that sometimes confuses people. They think, well, there's an acute MI happening, but it's not an acute. The computer is picking up the Q wave, and at that point it says, this person's had a previous infarction, but not today. So therefore, it's looking at the old scar in the heart. The today stuff is T wave being elevated, ST segment elevation. The Q wave is purely what happened, who knows, not today. So it's not an acute event. And we see that very often when people go to their doctor, they get a 12 lead done for a routine purpose, just for an insurance physical, and then their doctor will tell them, Jim, you must have had a heart attack at one point. He's like, really? And he's like, yeah, the machine says inferior infarct, age is determined, but it may be picking up a small Q wave somewhere else, but this makes it very difficult to actually get insurance for some people. And when we teach 12 leads to the medical students, invariably some of them will actually have physiologic Q waves, so very small Q waves, and those people's cardiograms will say inferior infarct, age undetermined, so all of a sudden you have all these little kids thinking that, oh my God, I've had an MI before, I don't remember it. And so that also is clinically relevant to you guys as paramedics, because when you arrive people, you'll say, have you ever had a heart attack before? And you'll be like, yes. And you'll say to them, well, when you had your heart attack, what did it feel like? And they'll say, oh, I never had any pain. I went to my doctor and he told me that I had a heart attack before. Well, that guy probably has not had a heart attack. He actually just needs a smarter doctor.
Awesome. Hopefully it wasn't me that he saw.
Oh, darn.
No. Okay. Again, looking at some of the morphologies, peak T wave, evidence of potential impending cardiac ischemia or things going wrong, pissed off T wave. ST depression is also a good indicator. We'll talk about it a little bit later. This slide's a bit confusing, so I'm going to go over it real quick. T wave inversion is another possible another piece of evidence against for cardiac ischemia, and then ST elevation, of course, which we're most focused on here, and the Q wave will go over again. I don't know why that slide is in there, so I have to probably take that one out.
Okay.
I don't like that one.
Okay.
So let's talk again about hyperacute T waves. Those again are important. Those big, tall peaks, and they show up within minutes of blood flow interruption. So the heart's pissed. It's saying, get it back right now.
The heart is angry.
Yes, sorry. Mike tried to remind me to be appropriate. I think I'm doing okay so far.
You're doing better for you, yes.
Okay, so it's the earliest ECG finding, and it could manifest as ST depression later or inverted T waves later on, or it could become the big honkin' ST elevation MI that you're waiting to see, and you might want to repeat that cardiogram on the way if you have time, and if not, then we'll repeat it when we get in the department. Sometimes we'll sit on a patient who has tall, looking like hyperacute T waves down in the emergency department for a couple of hours. Treat them for their pain, treat them for a presumptive ST elevation MI, and wait to see if it actually involves. The differential diagnosis is huge, but three of the most important ones are hyperkalemia, benign early repolarization, and then left ventricular hypertrophy, which I'll probably, a talk for an hour that we could do all on its own.
Yeah, let's not.
Okay.
But think of the T waves as like a tent that holds potassium. So therefore, the larger the T wave, the more potassium you have around. So the differential, as Karen alludes to, could be hyperkalemia. You're going to see that in your dialysis patients that skip their dialysis, or someone who has got a risk factor for hyperkalemia. And so sometimes we actually see very dangerous elevations in people's potassium that can be seen by the actual T waves themselves. So here's a good example of hyperacute T waves here. So if you take a moment to look at this cardiogram, I'll give you a hint. They're in the anterior lead.
All right. That's a good moment.
That's a good moment.
Okay. Subendocardial ischemia. So inadequate oxygen to the tissue, and it can be represented by ST depression or T-wave inversion. So this is looking at somebody who's having ischemia but not having that big honkin' ST elevation MI that we can actually bypass and take to the cath lab. So those are that little slide that I think is sort of inappropriately placed. We're talking about other markers of acute myocardial infarction. Ischemia can be represented by the ST depression, so looking the same way, it's just going the opposite way, just like we saw with the, or we talked about with the potential posterior infarct. But if you're seeing those in the anterior leads, you're seeing some ST depression that's going out laterally, you're wondering if this is going to evolve into ST elevation, or it could be that that's all you're going to get in a subendocardial or subtotal ischemia to that portion of the heart.
Well, this is really where the pre-hospital ECG for an emergency physician is very helpful outside of infarction, because many of the times when you go to see people, you see them at their worst. So you apply the 12 lead and you're going to see the T-wave changes with the ST segment depression. But then by the time we get to see them emerge, you've given them oxygen, you've given them nitroglycerin, you've given them aspirin, and their chest pain goes away, and the ischemia can actually change, and the T-waves will go back to normal again, the ST segments will go back to normal. So we missed out on the opportunity to see their ECG with pain, similar to this cardiogram here, and potentially we may send them home when really, at the end of the day, we want to see them with their ECG with pain.
Yeah, and this is super important when you guys have done the 12 leads out, that we actually get to see them in the emergency department, that the physician responsible for that patient gets to see it, because this is very critical. Take a look at this ECG where you have pretty diffuse ST depression. This is a pissed off heart. Why?
It's an angry heart.
Sorry. This is a very angry heart. I'm doing it again. This could represent subendocardial injury, so there's been an insult to that angry heart.
Nice.
Or it's going to move into a more significant ST elevation infarct that we can actually do something more aggressively about in terms of calling in those cardiologists and waking them up. And if you see this, make sure that the physician that you present this patient to in the department actually gets this, because it may resolve. It may look relatively normal by the time we get a formal 12 lead in the department.
I know the medics are frustrated in the fact they do these 12 leads, and all of a sudden it seems like no one actually pays attention to the 12 leads. But Matt Davis, one of our residents who's our EMS fellow, has actually done a study looking at how often this actually changes our management if we were able to have the 12 leads. So we're working on a process to actually adopt these 12 leads directly into the actual records, so we can make a decision about them quite quickly.
Okay, we're going to try and move on a little bit, because now there's a few more things we want to get through. I maybe need to go through this one.
Yeah, no, injury, yeah. So for sure, these are the things you're going to see with regard to injury. And if you have actually a transmural infarction, then you're going to get ST segment elevation. So ischemia, T-wave inversion, ST segment depression, but the moment you're actually losing cells, that's when you're going to see your ST segments go up.
Okay.
So there's an infarct on this cardiogram, and so when someone hands me a cardiogram, the first thing I do is I go, okay, well, is there something time sensitive? So I scan the territories very quickly. So I go, okay, septal, good. Nothing horrible. Anterior, all right. Lateral, oh, look, on the high lateral wall, there's a bit of T-wave changes there and some ST segment depression, and one in AVL. So, oh, look, in 2, 3 in AVF, that's clearly some ST segment elevation. So I just scan territories. Everyone's going to have their own approach, but I just look for big, bad, and ugly things in different territories.
So this is showing us that there's something going on in the heart. There's injury occurring. Next thing we're going to talk about is infarct, when there's death of the tissue already. It's represented by the Q wave, and we already talked quite a bit about this too, just with some of my stories about outpatient ECGs and saying there's a Q wave there. Well, a physiologic Q wave should be less than 0.04 seconds. So it's there. It's a negative deflection that starts the QRS complex, but it's short, it's small, it's needed, it's discrete, it's a tiny little guy, whereas a pathologic Q wave is going to be greater than 0.4 seconds. So, or sorry, 0.04 seconds. So when you look at this, and you can say, well, yeah, those look physiologic, and usually your printouts are going to pick that up based on those measurements. If you don't have one, you can look super smart when you say, well, that's really tiny, that's nothing. But what does this really mean to you in the acute setting? Not a whole lot, because that's already dead tissue. So if you do see a pathologic Q wave, it might just tell you that this patient's at further risk for ongoing injury or for injury that might occur based on their story. We'll take a look at some Q waves in this ECG. Take a look at the anterior leads, which should those go down? Should those be initial negative deflections? Or those are the place in the heart where it should be the most positive? That's V1, V2, V3, right over the left ventricle, where all of that energy should be coming right out at you. And here it's going down negative, and those are Q waves.
We also have some, it looks to be some Q waves inferiorly here too. And so when you see someone who said, I've had a previous MI before, sometimes you can look at the cardiogram and see what territory has Q waves in, and that tells you what artery was the diseased artery. But again, too much emphasis on Q waves. As paramedics and as emergency physicians, we shouldn't really care about Q waves. It's kind of like picking up someone and you look at their arm, they have an old healed scar on their arm, you're like, hey, you fell off your bike like 10 years ago. Who cares? But if they're acutely bleeding and they fell off their bike today, they're going to have ST segment elevation or T wave elevation or inversion. They're not going to have Q waves.
So we're moving to reciprocal change right now, which to me, same kind of story. Not as exciting as seeing the ST elevation, but if you're looking in the right areas, and as you get more accustomed to looking at the heart with the coronary artery supply, you can see where there should be reciprocal changes. It takes a little while to conceptualize, and I don't know, that should be the major part of the focus of today's talk, so we'll try and get Mike to sum it up for you with one of his silly stories.
I think that the reciprocal change, all you really care about is that if you're looking at someone who's got a cardiogram, you think there's ST segment elevation, and you're wondering if it's J point elevation, or if you're wondering if it's actually true infarction, well, at that point, you can look and scan other places in the cardiogram and you see ST segment depression or T wave inversion. So the opposite change of the elevation you see, well, chances are that sort of tells you that, no, that probably is truly ST segment elevation of an ischemia or injury or infarction point of view, not just from a benign earlier polarization or J point elevation. So if you see up in some areas and down in others, it's bad. And that's the take-home message with reciprocal changes. And you can see here the nice sort of inferior infarction with some reciprocal change happening in the lateral leads, and even actually in V1, V2, and V3, there's some ST segment depression. And what's the opposite of anterior?
Posterior.
Posterior. And what's the opposite of elevation?
Depression.
So this may actually be an infero-posterior infarction, or this may actually be someone who's got reciprocal change in the anterior leads. So.
If you do want to practice, back in the grid, the color-coded grid, probably 20 slides back, there is an indication of where the reciprocal changes should be for an ST elevation infarct there. So you can go back to that slide as you're practicing getting your orientation around the heart, if you wish.
But at the end of the day, it's usually the lateral leads that have the reciprocal changes. The lateral leads, they're kind of like the people that sit on the side of the place criticizing people. Like, they're like, yeah, there's an infarct over there. They just would go with anybody, the lateral leads.
Kind of like you.
Yeah, kind of. They sit in the cheap seats and go, yeah, there's an infarct over there. Who cares about the lateral leads?
So really important point here, that a normal 12-lead ECG does not rule out acute myocardial infarction. So there are all kinds of little things that do not cause acute ST elevation where the heart is still dying. So that's the reason why we keep those patients that you bring in around for 6 to 8 hours to take a look at their cardiac enzymes, their CK troponins, because they may have had infarct in one of the smaller vessels that may not show, or it's a subendocardial lesion that doesn't have the same amount of energy that we can actually see on the ECG. So those things we're looking for change in the cardiogram over time, and then elevation of their cardiac troponins. Okay.
So basically, the ECG is very helpful. If it's up, it's up. That means what specificity means. If you have ST segment elevation and it looks like acute MI in your pre-hospital ECG, chances are it really is an infarction. But if you actually have ST segment elevation, you don't see elevation, your cardiogram is normal, it does not rule out MI. And so it doesn't, that's what sensitivity is about. So no STEMI on pre-hospital ECG, 68% of them will not have an infarction, but that's not 100%. So that's why we bring people and follow them like Carolyn was talking about.
All right, so let's do a little bit of practice here. So we'll give you we'll stop talking.
Oh.
I know that's hard for us. But
yeah, sure.
Stop talking and let you have a look at this.
It's like Jeopardy. Which someone in here is having an MI? So I usually scan territories, look 2, 3 in AVF, not horrible, maybe a T-wave inversion in 3 in AVF, but it's not the big bad and ugly stuff. Lateral wall, high lateral, 1 in AVL, maybe a bit of ST segment elevation in AVL, but then as you scan over to V1, V2, V3, wow, there's some pretty impressive ST segment elevation there. Now, there's also some notching on the ST segment here, and we had a question earlier about Osborne waves, and so the nice thing about 12-lead is the more you go into it, the further you deeply get into it, the more complex it becomes, and there's all these different types of waves and other things we can find. An Osborne wave is basically a notching or an abnormal ST segment change following the QRS complex seen in hypothermia. And so Osborne waves, yeah, that's hypothermia. But so you'd be amazed at what other things you can pick up on a cardiogram just by the more we go into it. And that's the fun part about this course, is that if you have the 12-week course, we get the building blocks in it, and we can always expand on it in the future with regard to education. But so to answer the question, Osborne waves, yeah, that's typically seen as notching or different ST segment change following the QRS in hypothermia.
So in summary, this ECG is an extensive anterior, which would be your left branches of your left main coronary artery.
Almost like an interoceptal, because there's definitely elevation in V1
Yep.
and V2 here.
Be your LAD plus your circumflex. Okay, next one.
So here is a good example of the hyperacute T waves. So ST segment elevation for sure, V2, V3, with some impressive T waves in V4 and V5. So and you're seeing some reciprocal change inferiorly here with 2, 3 and AVF, with some scooping of the ST segment and also some T wave inversion. Nice, yeah. Carolyn's pointing out to V3 here. You can really see here that that does not look like J point elevation. That's clear, strong elevation to the ST segment.
All right, it's just a good one to practice, looking at where that J point is and seeing the elevation after where your J point is.
Hey, Karen, look at AVR.
That might have worked 6 years ago.
Whatever.
Okay, next one.
So I think we've seen this cardiogram earlier in the presentation. It's a nice example of an inferior infarction, but with impressive reciprocal changes, one in AVL as well as in V1, V2, V3. So yet again, that could be just inferior infarct with reciprocal change, or it could be an inferior posterior infarction, which really speaks to a large territory. And if anyone's going to actually have a RV infarction, a right ventricular infarction, it's going to look a lot like this. So an inferior infarction with bradycardia, very sensitive to preload, but again, it doesn't change the nitro protocol, but of those that are going to drop their pressure and become hypotensive with nitro, it's going to be this patient here. Another inferior infarction, and just because you're an inferior infarction doesn't mean it's not as a good infarction as other infarctions. You know? This infarction is inferior. I need an anterior infarction.
It still sucks.
It's still, no, it's not the best.
Darn.
Potty mouth.
It's actually really unusual that I'm you know, more inappropriate than you are.
That's true.
Okay. This is our last practice slide.
Yeah, so this is an impressive, very large anterior infarction with huge ST segment elevation as well as hyperacute T waves.
And before he tells you, where do you see the depression here? Yeah, okay.
Well, are you waiting for someone to answer?
Well, no, I'm just giving them a second to think about it.
So you see the inferior ST segment depression here. So very impressive infarction. But when you see this, it's actually almost global ST segment elevation in some areas, because it's going all the way from V1 all the way out to the high lateral wall. But there's definitely reciprocal change inferiorly. So a nasty looking cardiogram for sure.
All right.
We're going to get on into the
We're
time.
getting to some summary slides here again.
Good.
Greater than 1 millimeter of ST elevation in the limb leads, greater than 2 in the chest leads, 2 contiguous leads. Try to know where you're looking. See the electrodes as an eye or as the camera in those previous slides, and memorize those lead locations however convoluted your way of memorizing it is.
I like my way. I like my way. A brief word about imitators. So every time you see ST segment elevation, there's other things that can mimic it. And so it's important to not be offended if all of a sudden you come in with something that's a ST segment elevation, you're like, I'm calling this infarction, but then we look at it and go, oh, it's a bundle branch block or LVH. It takes years of getting used to cardiograms. It could be benign or liver polarization. All of these can mimic ST segment elevation caused by an acute MI. So you can go through all the different imitators and learn about them, but at the end of the day, suffice it to say that everything that is ST segment elevation is not necessarily acute MI, but we should act on it as if it is, if they've got a good story.
Yeah, and remember, in terms of bundle branch block, if you're using the normal conduction pathway, things should happen quickly. Things should be all in nice, tight packages, moving through the QRS complex and the T-wave repolarization. If you're driving through the cornfield, if you're going through the muscle and not using the normal conduction pathway as in terms of a bundle branch block, things are going to take a lot longer, so you're going to be widening out. That's another way to remember it.
Right, so it's going to be odd because you're going to see evidence of supraventricular conduction. You're going to see P waves matched every QRS, but the QRS is wide, so therefore it has to be supraventricular, But P waves match to a Y complex, you got to think aberrant or abnormal conduction, which is a bundle branch block. And the block terminology here is not the rhythm, it just means the QRS has abnormal conduction. So you can see here, if you lose the left bundle, the left ventricle, the left bundle of the ventricle, impulses will spread down the right bundle and then move through muscle to the left. And that's why our left bundle branch block has a Y complex QRS. But you're still going to see the P wave with it because that's atrial contraction, and the impulse is still beginning at the SA node.
And remember that if you're looking for a bundle branch, there still has to be a supraventricular initiation. So you're looking for that P wave, something that's happening up above the ventricles and then spreading down into the ventricles either quickly or slowly with the wide complex. Otherwise, you might be looking at something that's ventricularly generated in terms of ventricular tachycardia.
Or an idioventricular escape rhythm, which is going to be Y, but no P waves. And also it tends to be quite bradycardic. So very low, very wide, very slow, no P waves, idioventricular. Very fast, very wide, no P waves, VTAC.
Okay, so I think going over the bundle branch block identification, I think that you've gone over this in your previous courses with cardiogram classes. So trying to figure out if it's a left bundle branch block or a right bundle branch block, which actually until I went through this particular presentation, I've heard this turn signal methodology, but I was never taught it. So.
Yeah, I'm proud to say that this is not mine. I don't believe in the turn signal. So the bottom line is this. The best thing looking at bundle branches, deciphering one versus the other, is the computer. So if the computer says right bundle, it's a right bundle. If it's a left bundle, it's left. But if you really want something to memorize, you look at V1. And if you're positive in V1, you have a tall R wave in V1, it's a right bundle branch block. If you have negative in V1, it's a left bundle branch block. And some people use the turn signal analogy, which is basically you're driving your car down the road and you want to turn left. Carolyn, which way do you move the turn signal lever?
I would never learn this way.
You never use your signal?
No,
is that why?
of course not.
You're sort of use your middle finger for driving?
Drive faster.
That's right. So you turn down to turn left, you put your turn signal down and you turn left. So a left bundle branch block is down in V1. Whereas you want to turn right, you turn the turn signal up. So it's up in V1. I hate that acronym, so let's skip it. Depending on where you work, you may have a bypass protocol. I know that a lot of things we do in the emergency department and also things we do in EMS, they may not be evidence-based or they may not necessarily be directly tied to mortality. 12-lead ECGs shortened, pre-hospital shortened door-to-needle times for thrombolysis, and also pre-hospital ECGs can also shorten your time to your balloon for your plasty. So if we're doing a direct-to-PCI or direct-to the cath lab protocol in some areas, and as we expand through EMS to the province, that's where the directions we're going in these centers of excellence where we break it right from the field to the cath lab. We're saving people's lives. We're shortening their infarction time, shortening their ischemia time, reducing the amount of infarction territory, reducing the number of people in CHF. So this makes a huge difference. So depending on where you work, you may be part of a STEMI bypass agreement, and they're expanding all the time throughout the region. That's one of our major focuses of meetings these days. So look for it coming near you, but regardless if you're part of a PCI program, doing a pre-hospital 12-lead ECG shortens the door-to-needle time for thrombolysis, and it makes a big difference. Because our ECG time at LHSC is actually 20 to 25 minutes to get a cardiogram when you walk in the door. But if you walk in the door with your 12-lead done and say, look, this person's having an acute MI, we've saved that person 25 minutes. And we've shunted some people from the 2-hour window to the 4-hour window, and we're saving people's lives.
Excellent.
Is that all we have to say?
That's pretty much all we have to say. So if there's any questions, we're happy to take them now. And just while you might be chatting them in, just want to say thanks for your attention this morning. We hope you had a little bit of fun with us. Too bad you couldn't talk back to Mike because that makes things all the more enjoyable for me. But
yeah.
But Carolyn,
yeah.
Nice day. We've got the opportunity, if you've got a few minutes, if anybody does want to ask a question, if you have a mic and speakers at home, if you look on your control box, those of you who are attending at home, you'll see a little picture of a hand. And if you click on that hand, I'll see it on my screen. If you want to ask a question live, I'll just forewarn you though, when you ask it live, everybody gets to hear your question. Not like the chat box where it's all behind the scenes. So if anybody's got a question for either Dr. Llewellyn or Dr. Church, I'm also going to see, I'm not sure, Adam Duclo has also been on the presentation. He's just been itching to get in, but I'm not sure if his mic's working. Adam, just give you a heads up, I've turned your microphone on just in case it is working. But I don't think his mic was working from where he is at today.
That might be a
So
good
if anybody does have a question, if they want to put their hand up, otherwise.
Oh dear.
Is everybody okay?
Oh, did we lose everybody?
Oh no.
Okay. Well, I don't see any hands popping up, so we're just over the 1 hour mark, but time flies when you're having fun. So Dr. Church, thank you very much for that presentation. There's quite a number of questions in the background, which is good, and I think you've addressed them all live as well as on the chat box at the back. Just so that everybody remembers that this has been recorded, so you'll be able to go onto our website, you'll be able to play back the live webinar and hear it all over again. We even had one person suggest that this would make a great DJ on XM satellite. We'll have the medical channel with Mike and Carolyn in the morning show.
That's awesome.
I think they might have to beep out some of my my terminology there.
Perhaps.
Yeah.
Okay, Adam, I just unmuted you again. Adam, are you there?
That XM channel is EM Rap.
Yeah, we'll call it the SWORBHP channel or something. So,
Well, thanks everyone for coming.
okay, thanks all.
Have a good day.
Thanks, guys.